Morning, everyone. I'm just going to give a couple more minutes to see if we have any late joiners. Okay, why don't I get started? I'm Chris Lazonga. For those of you that don't know me, I'm one of the intensivists at the General and Birchmount sites, and I'm also a toxicologist at the Poison Center. And on behalf of the Division of Clinical Pharmacology, I'm going to be presenting grand rounds today. Let me see here. Jeez. Doesn't look like you can see my slides here. Let me just see if I can sort this out. There we go. Can you guys see those slides okay?
Yes.
Great. All right, so this is a review of a case that we had at the Birchmount site a few months ago. It was a severe calcium channel blocker overdose, and you'll see why the title is there in a moment. The case presentation was as follows. A 45-year-old woman presented to the Birchmount Emergency Department after an intentional ingestion of amlodipine. It was absolutely massive ingestion, 200 tablets in an intentional suicide attempt. And of note, her mother presented at the same time, also with an ingestion of 158 tablets in a suicide attempt. Neither had any co-ingestion of other pills, and they presented to the emergency department about 4 to 6 hours after ingestion. It was a very challenging case, I think emotionally as well. The younger of the two ladies was, had been dealing with the death of her husband a few months prior, and somehow had arranged a suicide pact with her mother. And so when the daughter attempted suicide first, then the mother found her a couple hours later, decided to also undergo the attempt, and a few hours after ingestion, when the daughter saw that the mother wasn't feeling very well, I think she regretted her decision and called EMS, and they both came to the emergency department. On arrival, they were both hypotensive. The daughter had a blood pressure of 72/46, heart rate of 109. The mother had somewhat more severe hypotension, 58/41, and a heart rate of 79. Level of consciousness was preserved for both of them. Chest was clear on room air, abdomen benign. Both had lactic acidosis. The daughter had, because she had ingested a couple of hours prior to the mother, had a lactate of 11.5. The mother's lactate was 3.9. They both had evidence of acute kidney injury with creatinines of 157 and 148 respectively. And they underwent kind of the standard initial resuscitation in the emergency department with intravenous crystalloids and vasopressors and inotropes, calcium salts, consultation with the poison center, and ultimately admission to our intensive care unit. Before I get into a lot of details, if anybody is interested in learning more about pharmacology of all sorts of cardiovascular drugs, this website is incredibly helpful, cvpharmacology.com, and it goes into far more detail about mechanism of action than you've ever wanted. And a lot of the images that you'll see today are from this website. So, whenever I talk about calcium channel blockers at the Poison Center, I also like to throw in beta blockers because our treatment has significant overlap, and of course the clinical presentation has significant overlap. So we all know about our beta adrenergic receptors. There are 3 isoforms in the body. Beta 1 receptors are the ones we're primarily interested in because they are found on the cardiac myocytes, in the sinoatrial and AV nodal tissue, as well as in the conducting system. They have 4 actions. Beta 1 receptor stimulation causes chronotropy, an increase in heart rate. It causes inotropy, an increase in contractility. It causes dromotropy, which is an increase in the rate of electrical conduction. And the 4th action, which is a little bit less studied, is lusitropy, or an increase in the relaxation of the myocardium. We also have beta 2 receptors found on cardiac, but also on smooth muscle cells, primarily vascular and bronchial cells. The actions of stimulation of beta 2 receptors include vasodilation and bronchodilation. And then beta 3 receptors, which are not all that important clinically, are found on skeletal and adipose tissue and mediate thermogenesis and lipolysis. So the beta-1 receptors in the heart, are stimulated through norepinephrine being released from the synaptic nerves, but also circulating catecholamines, and they act through this G protein. So they're a G protein coupled receptor, and the G protein stimulates adenylyl cyclase, which converts ATP into cyclic AMP. And then the cyclic AMP is an important second messenger in the cell that leads to activation of protein kinase A, leads to calcium influx into the cell and calcium into the sarcoplasmic reticulum. And that intracellular calcium and this calcium that's released from the sarcoplasmic reticulum causes the myocardial contraction, as well as similar mechanisms for all the other actions of the receptor. For beta-2 receptors in the vessels, the similar kind of setup. We have a beta-2 receptor coupled to a G protein with ATP and cyclic AMP being the second messenger again, and calcium influx through L-type calcium channels, binds calmodulin, and leads to the final downstream effects. So beta blockers are competitive antagonists that bind beta adrenergic receptors. They prevent binding of norepinephrine and epinephrine at all of these sites. In clinical use, we distinguish between cardioselective and non-cardioselective beta blockers, but the distinction is not important in overdose because the tissue levels of beta blockers are so much higher than the affinity of the individual compounds for the receptors, and so that selectivity is lost. Which is a common feature of overdose. And the main effects seen clinically are negative inotropy, negative chronotropy, negative dromotropy, and vasodilation. For calcium channels, it's an analogous story, but they just act downstream of the beta blockers, right? So we have our L-type calcium channels on the various cells. In vascular smooth muscle, calcium channel stimulation or calcium channel functions mediates vasoconstriction, and in cardiac myocytes, it mediates inotropy, as well as in the sinoatrial and AV nodal tissue, it stimulates chronotropy and dromotropy. So all of the same clinical effects. We have three groups of calcium channel blockers: the dihydropyridines, which are vascular selective, verapamil, which is cardiac selective, and diltiazem, which is non-selective, but the effects are primarily seen on the cardiac tissue. But again, this distinction is lost in overdose, and you get very similar clinical presentations with overdoses of any agent. And the clinical presentation is exactly what we saw in our cases: cardiogenic shock, including hypotension, bradycardia, AV nodal blockade, cool clammy extremities from the low cardiac output state. You can develop peripheral edema with prolonged exposure, not usually seen much in acute overdose. And then how can we distinguish between calcium channel blocker overdose and beta blocker overdoses? This used to be a favorite exam question. In calcium channel blocker overdoses, we typically have hyperglycemia because insulin release from the pancreas is mediated by calcium channels, and as part of the shock response, you're going to get glycogenolysis, and it will tend to increase your serum glucose levels, and that can't be counteracted by the insulin release from the pancreas that normally occurs. With beta blockers, we get often relative hypoglycemia because we're interfering with glycogenolysis and gluconeogenesis in the liver, and so the blood sugar tends not to rise. And this was exactly what was seen in our cases. We had calcium channel blocker overdoses and therefore had some degree of hyperglycemia in both cases, with blood glucose around 12 for both of the patients. So our management, which is really the core part of this presentation today. We have our general resuscitative measures, including securing the airway and breathing, neither of which are usually a major concern in calcium channel blocker or beta blocker overdose. But circulation is really where our focus is, right? And as we saw in this case, we administered fluids and we started inotropes and vasopressors. The important consideration, I think, with inotrope and vasopressor management of these patients is that you really want to target adequate perfusion, not a target blood pressure. And the reason for that is that a lot of these patients are going to have poor cardiac output and true cardiogenic shock more so than vasoplegia. And by raising the systemic blood pressure with an alpha agonist, or primarily with alpha agonist like norepinephrine, you may increase the afterload on the left ventricle too suddenly, and you can actually worsen the cardiac output even if the blood pressure comes back to the normal range. So it's important to try to assess these patients and try to determine which phenotype of shock they're exhibiting. Is this primarily cardiogenic shock or primarily vasoplegic shock? And tailor your inotropic or vasopressor management to either of those shock states, as well as some of the other treatment measures that we're going to talk about shortly. Electrical pacing can be used if the patients have severe bradycardia or complete heart block. Of course, it does not provide any inotropic support, and therefore it's not often used in either of these overdoses. But if you did have a patient who had reasonable cardiac function and was just bradycardic, you could try pacing that patient if needed. Decontamination. So this is our standard ABCDE model of management for toxicology. It goes through ABCs, and then D is for decontamination. All of the beta blockers and Chalice channel blockers are potentially responsive to charcoal, single dose activated charcoal. We'd consider it within the first 2 hours, ideally within the first 60 to 90 minutes of ingestion. And they would bind non-specifically. The main risk of charcoal is one of aspiration. So if the level of consciousness is decreased, then the risk of charcoal start to increase rapidly. And so, the longer the time from ingestion and the worse the level of consciousness is, the less likely we are to recommend charcoal administration. And similarly, whole bowel irrigation. So whole bowel irrigation we use for extended release preparations, and diltiazem and nifedipine are the ones that you'll see most commonly as extended release drugs in Canada. But there are some others, like in the US, they have extended release metoprolol, and things like that. Again, the same consideration for aspiration exists for whole bowel irrigation, and even more so because it's a very large volume of fluid. So if we know that we're dealing with an extended release drug like diltiazem, if we have a secured airway, the patient's intubated, then we're very likely to recommend whole bowel irrigation. If the patient is very drowsy, then obviously we would not. And then finally, enhanced elimination. So typically when we're talking about enhanced elimination, we talk about hemodialysis for these patients, and ideally intermittent hemodialysis, since that has the highest clearance rate. The ones that are dialysable are exclusively beta blockers, and the one they're listed here: sotalol, atenolol, nadolol, timolol, and acebutolol. Lipid rescue has become also a consideration. So lipid rescue is just the administration of a large bolus of very lipid-rich solution. In this case, we use the lipid component of TPN, and we administer that for patients who have a very lipophilic drug overdose. And how we usually identify those drugs is by looking at the log P, or the partition coefficient. Log P is the concentration of a drug in an octanol solution divided by the concentration of the drug in water, and then we take the logarithm of that quotient and we get the log P. So anything 3 or above means a drug is at least 1,000 more times more soluble in lipid solution than water, and somewhere around 2.7 is our usual cutoff for whether a drug is likely to respond to intralipid management. The idea being that if we create this large lipid component in the bloodstream, then we will be able to sequester very lipid-rich drugs in that component and actually draw them out of the tissues and maybe decrease the tissue concentration of the drug enough that they'll no longer be toxic. And so, this is very helpful for drugs like labetalol or carvedilol overdoses, amlodipine, diltiazem, and then not so helpful for hydrophilic drugs like the dialysable beta blockers, metoprolol, bisoprolol, and nifedipine. So these can be determined from just a quick Google search. If you search log-P and then the drug name, you'll find many sources that list the partition coefficient for all of these drugs, and that can help guide you as to whether or not you expect lipid rescue to be helpful for these agents. All right, so now we can get into the specific agents that we might use as antidotal therapy for beta blocker and calcium channel blocker overdose. So historically, glucagon was the primary antidote for beta blocker overdose. It has a very elegant pharmacodynamic mechanism for that, because it actually binds to this same, the glucagon receptor is also bound to this same G protein that the beta receptor is bound to. And so you can stimulate the downstream signaling cascade independently of the beta blockade, which helps you get around it. And it's very helpful for beta blocker overdose. It works, but we've kind of gotten away from it for the past 15 or 20 years because of a number of downsides from the drug itself. Glucagon is very expensive and has a very short shelf life. And because of that, most hospitals have very low supplies of the drug, often not enough to adequately treat even one severe beta blocker overdose. It also exhibits tachyphylaxis, so the body adapts to constant stimulation with glucagon and down-regulates the surface receptors, and therefore it stops working after about a day or so. It's also a drug that in high doses causes nausea and vomiting, and for patients who are bradycardic, they will sometimes get a very profound vagal response to the nausea and vomiting, and can have bradycardia or cardiac arrest. And so for all of these reasons, we've kind of moved away from glucagon for beta blocker overdose to high-dose insulin, which is kind of the current standard of care for this therapy. There is a systematic review that was published back in 2003. That's listed here if people are interested in reading about glucagon therapy. But like I said, it's not all that readily available nowadays, and we've kind of moved on from it. And so the current the current therapy that we use primarily is high-dose insulin. So the first case report was in 1993 in a severe verapamil overdose. And then over the years, we had more case reports in animal studies, and now it's in widespread use. There are no randomized clinical trials of high-dose insulin. Toxicology is a very challenging field to run clinical trials in, and so this is kind of the level of evidence that we deal with all the time in toxicology. Insulin is very helpful. It can be used in conjunction with our inotropin vasotherapy, vasopressor therapy. The mechanism is somewhat unclear. It's thought that it provides a alternative energy source for stressed myocardial cells to use. So our myocardium at rest uses lipid synthesis, lipid metabolism for its energy supplies, but when the myocardium is stressed, it has to switch over to carbohydrates. And the idea is that high-dose insulin probably drives carbohydrates into the myocyte and allows a very ready energy source for use, and allows it to exert its inotropy as much as needed. There's some increased calcium release from the sarcoplasmic reticulum from high-dose insulin as well, and some other metabolic effects that are less well understood. But for whatever reason, it does seem to work for both beta blocker and calcium channel blocker overdose. The dosing of high-dose insulin is very high. It's about 10 times higher than what we use for DKA. Right? So instead of 0.1 units per kilogram per hour as a starting rate, we start at 1 unit per kilogram per hour, and we'll escalate as high as 5 or 10 units per kilogram per hour. And so this was an issue early on when we would propose it to emergency medicine physicians, because we'd be using massive doses of insulin. They were very worried about hypoglycemia. Interestingly, we don't see that much hypoglycemia when we institute this therapy. And I think that's probably due to a ceiling effect in the kinetics of glucose uptake into the myocardial cells. And so you kind of reach a maximal rate of glucose uptake, and you can keep up with that with dextrose administration in almost all cases. It's very rare to have severe hypoglycemia despite massive doses of insulin being given. Calcium salts are very commonly prescribed for calcium channel blocker overdose. It kind of, at first glance, it makes mechanistic sense. We've got a competitive antagonist at the calcium channel. So why don't we try to overcome that by flooding the body with calcium? Unfortunately, it doesn't really work very well. The serum calcium concentration is very tightly regulated within the body because it's so important to a wide range of metabolic effects, and the intracellular calcium concentration even more so. And so you do get an effect from calcium administration, but it's very short-lived. You get tachyphylaxis almost immediately. And there are some case reports describing its use, but I found that it only lasts 10 minutes or so when you do give it. So you really have to follow up with an alternative therapy. In terms of inotropes and vasopressors, we have non-catecholamine vasopressors that we can use, such as vasopressin. So vasopressin binds vasopressin receptors, not adrenergic receptors, and can be helpful if your patient has severe vasoplegia. It's a pure vasopressor, so it causes vasoconstriction with none of the cardiac effects. There's no inotropy, chromatropy, or dromotropy. So that's important to keep note of. If you have a patient with predominantly cardiogenic shock, then the unopposed vasoconstriction that's not matched by an increase in cardiac output can actually cause a deleterious effect on your tissue perfusion. Even though the blood pressure improves, ultimately your tissue and organ perfusion can get worse. Also, there's a ceiling dose to vasopressin because of the preponderance of vasopressin receptors on the splanchnic circulation. And so with high-dose vasopressin, you get severe gut ischemia, which limits us to 2.4 units per hour, or sometimes as high as 4.8 units per hour in clinical use. Once you get higher than that, you tend to get a lot of gut ischemia. So very helpful as an adjunct therapy, but not really as a primary antidote. On the other side of things, as an inotrope and a non-catecholamine inotrope, we have milrinone. Milrinone is a phosphodiesterase 3 inhibitor, and it prolongs the action of cyclic AMP. So again, bypassing the adrenergic blockade and acting downstream of it. It causes inotropy and vasodilation, so it's an inodilator. And one of the reasons why we don't use a lot of it in beta blocker overdose is because of this hypotension. And it's exacerbated by the duration of action. So all of our other inotropes and vasopressors are extremely short-acting. So if you run into problems, you can turn them off very quickly. Milrinone is renally cleared, and so and it has a longer duration of action anyway. So a patient with renal failure who you give a loading dose of milrinone to, they may have milrinone acting for 6 hours that you now have to deal with, and the vasodilation, if your patient had vasoplegic shock or vasoplegic component of the shock, can actually be very deleterious and impair your organ perfusion that way. So we don't use a lot of milrinone, but in the right setting where you have a patient who clearly has primary cardiogenic shock, it can be helpful. Alternative agents for vasoplegia would include methylene blue and hydroxycobalamin. Both of these have very similar mechanisms of action. They bind to and scavenge nitric oxide from our circulation, and they also inhibit nitric oxide synthase and preventing the synthesis of nitric oxide. So again, these will give you pure vasopressor effects, and it's important to select for the right phenotype of shock when you want to use these, because they're very powerful vasopressors. Choosing between the two of them is there's not much to choose between the two of them. Hydroxycobalamin is more expensive and less readily available than methylene blue because methylene blue is often used as an indicator dye in the operating room. They'll often have large stores of it in the OR if you need it. Methylene blue can cause serotonin syndrome in high doses. So keep that in mind. If the patient's already on a serotoninergic medication, you probably don't want to use methylene blue. But otherwise, that's the one I would default to. And then for patients who have refractory cardiogenic shock, we always have the option of mechanical support. And so you'd have to call over to Toronto General and get an opinion on suitability of VA ECMO, right? Veno-arterial ECMO. So in this case, we're going to take blood through a large bore cannula from the venous side of the circulation, run it through a membrane that's going to pass fresh gas over it, which removes carbon dioxide and oxygenates the blood. And then the pump is going to drive it back into the circulation. We're going to return it into the aorta on, as proximally to the aortic arch as we can to make sure that we get well oxygenated blood flowing to the central nervous system. It's not a cure-all. Number one, you can only use it for cardiogenic shock. It does not help with vasoplegic shock. And in fact, the circuit causes a low-grade inflammatory response and can worsen vasoplegia. So you have to choose the right patient for ECMO. And there are a lot of side effects, right? The circuit is thrombogenic, and so we have to anticoagulate the patients, so they have bleeding risk. Microthrombi tend to occur on the membrane, and then they flow directly into the arterial side of circulation, and so you get microthrombi in the kidneys, causing renal failure, and in the brain, causing post-pump cognitive dysfunction or encephalopathy. We've had patients come back to us from VA ECMO that had very profound encephalopathy that lasted for weeks and weeks. And so it's not, although it looks like a great rescue therapy and it can be in the right patient, it's definitely not a cure-all and very highly limited by availability. Right. And so Toronto General, for example, they won't put patients on pump unless they're very good physiologic candidates beforehand. So typically age less than 60, no significant comorbidities before they'll consider putting patients on pump. Some other pharmacologic considerations. There are some beta blockers that have intrinsic sympathomimetic activity, meaning that they're partial agonists. So acebutolol is kind of the main one there. Labetalol has a little bit of partial agonism, but not really important in clinical use. Acebutolol is a bit nasty in overdose because it will actually predispose you to tachyarrhythmias. And fortunately, it's very rarely used nowadays because of the tachyarrhythmia issue. There's also beta blockers that have membrane stabilizing activity, which means sodium channel blockade. So if the patient comes in on metoprolol or propranolol with a massive overdose, you just got to keep that in mind, watch the QRS duration, and if it starts to lengthen, you can give bicarbonate boluses to try to narrow it. And then there are some beta blockers that have alpha and beta blockade, like carvedilol and labetalol. They're still predominantly beta blockers, but do have some alpha blocking activity too. So these patients will tend to get more vasoplegic shock in proportion to the amount of cardiogenic shock that they get. But as you'll see from our case, you can get any type of shock from any agent. So how did these patients fare? Unfortunately, not very well. The younger lady was admitted to the intensive care unit. She was put on high-dose vasopressors and insulin. So insulin as high as 10 units per kilo per hour, norepinephrine at 200 micrograms per minute, which is somewhere around 5 times higher than our normal limits of norepinephrine infusions. Vasopressin at 3.2 units per hour. Clinically, she had very profound vasoplegia, but a near normal cardiac output on ultrasound. So, she was very much a vasoplegic shock phenotype. So we gave her methylene blue, we gave intralipid because the amlodipine is quite lipid soluble. She had a brief PEA arrest and was intubated and resuscitated in the ICU. After her arrest, her case was reviewed with Toronto General for ECMO, but she was, of course, declined because the phenotype of her shock was almost all vasoplegic and not cardiogenic. Unfortunately, despite our aggressive attempts to manage her hemodynamics, she became anuric, and given the massive doses of vasopressors that she was on, it was felt that we'd be unable to dialyze her even with continuous hemodialysis, and she expired in our intensive care unit 3 days after her admission. Her mother had a somewhat similar course. She was also on high-dose vasopressors and insulin. She had very much a mixed phenotype of shock with reduced cardiac output as well, and she was on 30 micrograms per minute of epinephrine in addition to the 200 micrograms per minute of norepinephrine. But she also had quite a lot of vasoplegia, so she got methylene blue and intralipid as well. She developed some acute lung injury from her ischemia reperfusion injury and was therefore intubated early on in her course. She also became anuric and was too hemodynamically unstable to tolerate dialysis. Her level of consciousness was quite well preserved throughout all of this, and so she was awake on the ventilator and actually asked us to palliate her because of everything. And this presented a very interesting ethical challenge because, normally we don't palliate patients post a suicide attempt because the vast majority of them actually do regret it and don't actually want to proceed to dying. But given that we were unable to dialyze her and she was anuric, her death was felt to be foreseeable and certain, and so we thought it was reasonable to palliate her. Her husband came in and we reviewed it with him, and he was supportive of that plan as well. And so she expired about 24 hours after her admission to the intensive care unit. So very unhappily, both patients died despite very thorough attempts to manage their hemodynamics and manage their calcium channel blocker overdoses, which I would say is pretty common for this size of overdose. Once you get over 100 tablets of beta blocker or a calcium channel blocker, it's unlikely that patients will survive. So I'll just offer a few final thoughts. When you're dealing with these patients, I think it's really important to identify the phenotype of shock, and that's going to guide your inotropic and vasopressor therapy as well as some of your antidotal therapy, and really try to resuscitate to adequate organ perfusion, not a blood pressure. Most patients will need a combination of high-dose insulin and inotrope or vasopressor support. Consider lipid rescue in the appropriate situation, and don't forget to call for ECMO support as a last resort if they have very low cardiac output. Sometimes you get lucky and the patients do get accepted, and they sometimes do well. So that is all I have for you guys today. If there's any questions, I see Alexis with her hand up.
Thanks, Chris. Great talk. I guess I'm curious, you kind of alluded to it a little bit in terms of looking at organ perfusion, but once you start patients on the high-dose insulin, how do you titrate that going forward?
Yeah, so you look at a combination of things. You look at blood pressure, you look at lactate elevation, which is a delayed measurement. It's not great. Urine output, mental status, capillary refill, and you kind of take all of those and try to build a picture of whether or not the patient has adequate cardiac output, adequate organ perfusion, and you titrate based on that. We'll very quickly move from 1 unit per kilo per hour to 5 units per kilo per hour. Once you get above that, there's kind of diminishing returns, and you don't get a lot more bang for your buck going higher than that, but kind of in that range. And then I would say we mainly use our normal vasopressors and inotropes to kind of titrate, finer adjustments to the patient's hemodynamic profile.
So once you're kind of committed to the insulin, you're going to titrate those vasopressors first and kind of think about the insulin later.
Yeah, vasopressors and inotropes are very fast to titrate, right? The patient responds within a couple of minutes, and the ICU nurses are very familiar with how to titrate them. And so that's kind of what I mainly use to titrate. And I just kind of try to get the insulin into a range where I think the patient's responding to it, and then, fine tune it with our normal catecholamines.
Thanks.
Faith?
Thanks, Chris. Great presentation and very tragic cases, very challenging to deal with. My question is actually very similar about the titration of the IV insulin. Once patients are getting better, I find it challenging to decide on titrating vasopressors down and off versus titrating the IV insulin first. Do you have an approach to getting patients off the IV insulin, and how much increase in vasopressors do you accept as you're coming off the IV insulin?
Yeah, that's always a challenge, and I didn't go into it here, but I think one of the reasons why the young lady arrested was probably over rapid titration off the insulin, because she actually seemed to do a bit better after 24 hours in the ICU, and we started coming down on the insulin, and she unfortunately had a cardiac arrest. So my approach is, very slow titration off of high dose insulin. Um, I usually try to wean the catecholamines first, try to get them into kind of our usual normal ranges before I start coming down on the insulin. Typically norepinephrine of between 20 and 30 micrograms per minute, epinephrine 1 to 10 mics per minute. Once we're in that range, then I would start thinking about titrating off of insulin, and I just go very slowly. Just drop it by 1 unit per kilo per hour every couple of hours. Make sure that the patient tolerates it. If I'm going back up on the catecholamines, then I would either just hold it there if the catecholamine requirements don't go up too much, or I just go back up on the insulin. There's no rush. High dose insulin is very well tolerated, and so if you end up running it longer than you expect, I think that's okay. Over rapid titration off, I think, is where we run into problems.
That makes sense. And do you take the half-life of the drug into account when you're deciding whether or not to start titrating the IV insulin off, or as soon as you start to see signs of improvement, you start to weed off the IV insulin?
Yeah, I don't really look at the half-life, and the reason for that is that when you get into these massive overdoses, the half-life is no longer relevant, because you switch from first-order kinetics of the drug to zero-order kinetics. So if you know anything about pharmacokinetics, first-order kinetics is when the drug clearance is proportional to the concentration of the drug. That's when you get your logarithmic or your exponential decay curve. When you exceed the body's capacity to metabolize the drug, you switch to zero-order kinetics, which means it's now independent of the drug concentration, and you have a fixed clearance of the drug over time. And that tends to be quite a bit slower than the half-life. And so with these massive overdoses, you don't actually have a half-life, and the duration is prolonged much more than you'd expect for the drug. So I don't do it based on the half-life. I do it based on the clinical response. The severe overdoses they're going to have massive vasopressor and inotropic requirements initially. And once those start to come down, and really once you get those into kind of our usual ICU ranges, that's when I start thinking about titrating off insulin.
Thank you.
Great. Okay, well, if there are no other questions, I think we'll leave it at that. And if anybody ever has interesting questions or interesting toxicology cases, feel free to contact me anytime.